Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Educational Series Educational Seminar. This evening, we're going to be talking about a targeted approach to the treatment of non-segmental vitiligo. As moderator, we have Dr. Brad Glick, who is a member of the AAD Board of Directors, Residency Program Director at the Larkin Palm Springs Hospital, PI GSI Clinical Research, ASDS Advocacy, Ambassador, and Miami, Florida. We also have Dr. Heather Woolery-Lloyd, who's Director of Skin of Color Division, Dr. Phillip Frost Department of Dermatology and Cutaneous Surgery, University of Miami, Miller School of Medicine in Miami, Florida. We would like to thank our supporter, Incyte Dermatology, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just click phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. Within 1 to 2 days of the webinar, a survey link will be emailed to you. We would greatly appreciate it if you could fill it out and send it back to us. So without further ado, I will pass the floor virtually to Dr. Brad Glick. Dr. Glick, you're muted.
Thanks, Roxanne. I'm so happy to be here this evening and here on behalf of Dr. Leon Kursick, and very happy to participate in this evening's IDEF. And if we can go to the next slide, please. The IDEF is founded by Dr. Leon Kursick. He is president of the International Dermatology Education Foundation. And the IDEF is a nonprofit organization whose principal mission is to raise awareness and improve dermatologic care all over the world through education, especially in underserved areas. Next slide, please. You'll see here some of the previous educational sessions, which include a variety of areas in dermatology. And as well, the IDEF has connected, particularly in the beginning of the pandemic and throughout these last 2 years, in areas that also engage a number of our industry partners. So stay tuned to many of those as well in the future. Next slide, please. It is my distinct pleasure to present to you again Dr. Heather Woolery-Lloyd, who is Director of the Skin of Color Division at the Dr. Phillip Frost Department of Dermatology and Cutaneous Surgery at the University of Miami School of Medicine. I also want to say that Dr. Woolery-Lloyd is not only board certified in dermatology, she's also board certified in lifestyle medicine. She is the founder as well of Derm Friends, which is a really cool app that recently has come into our dermatology space. I can't help but mention that, Heather, so I have to do that before we start to talk about this wonderful topic tonight of vitiligo, a targeted approach to vitiligo treatment. And so without further ado, Dr. Woolery-Lloyd, please go ahead and take the floor.
Thank you so much, Dr. Glick. I'm really excited to be here today to talk about a targeted approach to vitiligo. And really, I'm going to be talking about Opzelura, which is the first and only FDA-approved topical treatment for non-segmental vitiligo in adult and pediatric patients 12 years of age and older. Now, as Dr. Glick and Roxanne mentioned, I am the director of the Skin of Color Division at University of Miami. So I treat a lot of pigmentary disorders, and that's one of the reasons why I'm so excited to be here tonight to talk about vitiligo, because I've been practicing for around 20 years, and we really had nothing that was FDA approved, that we had really great studies that show that it worked for vitiligo. So this is really exciting for me to present this today, and I can't wait to show you all of this research. So this is a promotional presentation. It's sponsored by Incyte Corporation. I'm speaking on behalf of Incyte, and I'm being paid to give this talk, surprise. But I really am happy to be here today. I will be talking on the information I'll be presenting will be consistent with the US FDA regulations and in guidance with the US FDA approved label for Opzelura. So I really welcome your questions, but I will answer questions on label during this presentation. I'll also be presenting important safety information, and if you need more information, full prescribing information for Opzelura is available at this presentation. So Opzelura is actually indicated for two things. So it's indicated for the topical treatment of non-segmental vitiligo in adult and pediatric patients 12 years of age and older, and it's also indicated for the topical short-term and non-continuous chronic treatment of mild to moderate atopic dermatitis in non-immunocompromised adult and pediatric patients 12 years of age and older whose disease is not adequately controlled. Now, there is a limitations of use statement, and the use of Opzelura in combination with other therapeutic biologics like other JAK inhibitors or potent immunosuppressants is not recommended. So as you know, Opzelura is a JAK inhibitor. We're going to go into the mechanism of that because for a lot of that, it's a new concept. But JAK inhibitors were actually introduced several years ago and were first introduced into the rheumatology world. So they've been used to treat things like rheumatoid arthritis and other diseases that in the rheumatology world. So I want to present some important safety information that refers to this class of drugs, JAK inhibitors. So there have been reports of serious infections leading to hospitalization or death, including TB, bacterial, fungal, viral, and opportunistic infections in patients who have received JAK kinase inhibitors for inflammatory conditions in general. Higher rates of all-cause mortality, including sudden cardiovascular death, has also been observed in patients treated with JAK inhibitors for inflammatory conditions. Lymphoma malignancies have been observed in patients treated with JAK inhibitors for inflammatory conditions, and a higher rate of MACE, which is major adverse cardiac events like MIs and strokes have been observed in patients treated with JAK inhibitors, and thrombosis, including DVTs, PEs, and stroke have been observed in patients treated with this class of drugs. But at the end of this talk, I'm going to go into more detail about the important safety information, so you'll hear more about this at the end of this talk. So now let's jump into vitiligo, and I'm really excited to be here tonight to talk about vitiligo because it's something I do see in my practice every day on a regular basis, and we know it's an autoimmune disease, but we're going to delve a little bit into how we describe vitiligo, the burden of disease, and how we can manage these patients. So vitiligo, as I mentioned, is an autoimmune disease. We all know that. It's a chronic autoimmune disease, and most of our patients have a genetic predisposition. So we know 25 to 50% of people with vitiligo have a relative with vitiligo, and around 6% of people with vitiligo have a sibling with vitiligo. So our patients in general have a genetic condition, a genetic predisposition, and many of these patients have other autoimmune conditions. So I always ask my vitiligo patients about a family history of autoimmune disease. I'll ask about psoriasis, alopecia areata. I'll even ask about early graying, which is poliosis or going gray, early in the 30s, because some people consider that an autoimmune process. So I do find that these autoimmune diseases do tend to cluster together. And most of the time, patients will have some sort of family history of autoimmune illness. But that's just what people start with. Then there's a potential trigger. So the trigger can be a sunburn. It can be physical skin trauma. I've seen vitiligo at a site where I've done a biopsy. Chemical exposures can cause this. So I've seen vitiligo in men who dye their beards, and they have a reaction to the dye of their beard and develop vitiligo on the face. Of course, psychological stress is very common. Every skin disease that we treat, every single one, eczema, psoriasis, hair loss, every inflammatory skin disease that we treat gets worse with stress. As Dr. Glick mentioned, I am board certified in lifestyle medicine, and in the lifestyle medicine world, the area that they always mention the skin is under stress management, because our skin really manifests stress. If we're to have high levels of stress, we see it in our skin, and we all know that with all of these inflammatory skin diseases. And then there's an unknown trigger, which is what most of our patients have. Many patients will come in and we really can't identify a trigger. And I do emphasize that to patients because I want them to know it's not their fault. I don't want them to feel like they did something. If we don't identify something, I don't want them to feel like they did something that caused this. And for many, many patients, there's just an unknown trigger. Just they have this genetic disposition, and then out of the blue, those patients will develop vitiligo. So it's actually not an uncommon disease or condition. It's the most common depigmenting skin disorder worldwide, affecting 1.9 to 2.8 million adults in the United States, and around 50% of people with vitiligo develop the condition before the age of 20. So in my practice, I do tend to see patients who develop the disease a little bit younger in age, or before the age of 20. But I also do see a second peak in vitiligo in older patients. So I'll see new onset vitiligo in patients in their 60s and early 70s. And that's because a lot of the new chemotherapy agents and a lot of the immune mediated chemotherapy agents can sometimes cause vitiligo. So I've definitely seen that in my practice. But the vast majority of patients, or at least 50%, present before the age of 20. It is associated with other autoimmune conditions, as I've mentioned. So autoimmune thyroid disease probably has the strongest association. So when you have a new diagnosis of vitiligo, you should definitely check a TSH, but you should also consider checking thyroid autoantibodies like antithyroglobulin and others. And the reason why is that sometimes you can capture some early autoimmune thyroid disease before the TSH becomes abnormal. And this is especially true in pediatric patients. So if you have a new onset vitiligo patient and a peds patient, it's really important not only to check the ANA and the TSH, but I would also check thyroid autoantibodies because you might be able to find early autoimmune thyroid disease in these patients before their TSH actually becomes abnormal. And of course, it's also seen with alopecia areata. The other big take home is that vitiligo is seen in all people, all ethnicities, all skin types, all genders. So it's something that basically can affect everyone. So you hear me say that Opzelura is FDA approved for non-segmental vitiligo. What does that actually mean? It's a term, when we refer to vitiligo in our everyday practice, we are referring in general to non-segmental vitiligo. So non-segmental vitiligo progresses slowly, but it does have an unpredictable course. And I do find this to be one of the most challenging things with vitiligo because a new diagnosis of vitiligo for people can be very difficult. And the first question, if someone has gone to Google and looked it up, is this going to progress? Is this going to be all over my body? And the answer to that question is, I don't know. It's one of the most difficult things because we really don't know. We do know that the earlier age, if you develop vitiligo in childhood, it does tend to be a little bit more aggressive. But someone who presents in their 30s, I've had many patients who present in their 20s or 30s, and one patient could just have a little bit of vitiligo around the eyes and around the mouth and be stable for many years, and other patients will develop rapidly progressing diseases. So I will say that it is very unpredictable, and that's one of the hardest things about treating vitiligo. This is in contrast to segmental vitiligo, which is actually rapidly progressing and then stabilizes. So you can see here, this patient had segmental vitiligo on her arm here, in the picture here you can see on the abdomen, doesn't tend to cross the midline, rapidly progressing, and then it just stabilizes. And in segmental vitiligo, there tends to be early hair follicle involvement. So if you see white hairs and it doesn't cross the midline, you tend to think of segmental vitiligo, whereas non-segmental vitiligo can be vitiligo vulgaris, which you can see here tends to affect the folds, the acrofacial, which we do see a lot of with the hands and feet and on the face, universal when the whole body becomes depigmented, and then focal when it's a focal area. So the majority of the patients that we see in our everyday practice are non-segmental vitiligo patients. So now we're going to talk a little bit, there we go, about how patients, why they seek treatment. So our patients seek treatment for many different reasons. The affected area and extent of disease is important, but I think the affected area is one of the biggest drivers of treatment. So people who have vitiligo on the face are very aggressive and interested in treatment. It's something that's a real priority. And I think that's really important because we're going to talk about the clinical trial in a little bit, and the clinical trial that led to the approval of Opzelura. The primary endpoint was the facial vitiligo. And I think in my patients, at least, that's what's most important to them. But also the duration and progression of disease. Obviously, people who have rapidly progressing disease are very motivated to treat. Age of onset. So I definitely think in my pediatric patients, the parents are very, very motivated to treat. Skin type can play a role because darkly pigmented people have more of a contrast between their vitiligo affected skin and their normal skin. And so it's very, very obvious that they have vitiligo, and those patients tend to seek treatments. There's also a lot of cultural stigma on that last bullet, some cultural influences and social influences. In some cultures, vitiligo can be grounds for divorce. So there are a lot of different reasons why people seek treatment, and we need to take that into consideration. So here we're going to talk a little bit about the variability in body repigmentation. And this is really important to understand because we want to set realistic expectations for our patients. So we know that the areas that begin to repigment the fastest with therapy are areas that have a lot of hair. So if there's a high density of hair follicles, that area is likely to repigment quickly. And luckily for us, the face has a very high area of a high density of hair follicles, and that's why it is easier to repigment the face. And luckily that's great because that's what our patients are really most concerned about. But also the chest, arms, forearms, abdomen, and legs. So everything that you see here in green or turquoise. Now, areas that repigment a little more slowly with therapy are areas with a lower density of hair follicles. So you can see here the feet, the fingers, and the backs of the hands are going to repigment a little more slowly. And then it is important to understand the areas that may not repigment at all. And the one that for sure won't repigment is if there's leukotrichia or white hairs. And the reason why is because repigmentation usually comes from a reservoir of melanocyte stem cells. And if the hairs are white, that reservoir isn't there to repigment. So areas that have less hair follicles are the palms and the soles, obviously the volar wrist, very difficult to repigment, genital sites, the mucosa, and the semi-mucosal surfaces such as the lips. Those are hard. And if you see leukotrichia or terminal white hairs in a patch of vitiligo, this is very unlikely to repigment. And we should let our patients know, there's always a chance, but it's unlikely when there's depigmented hairs. So this is an interesting slide because it talks about an event basically that the FDA had. They had a public meeting, patient-focused, on drug development for vitiligo. So as I mentioned, I have been treating pigmentary disorders for around 20 years, and really we haven't had anything new or interesting in the last 20 years that was FDA approved to treat vitiligo. This Opzelura is actually the first drug to repigment, used FDA approved to repigment vitiligo. So the FDA recognized this and had a very large meeting, hundreds of people, to hear the patient's perspective on what it's like to have vitiligo. And these are just a few quotes from the people who attended this large FDA meeting. So one woman said, "My mother, she's Caucasian, but she went completely white. It was quite a challenge for her to live her life, challenge for her to live all that time turning white." And that's that progressive nature that I talked about, where some patients are very stable and other patients are not, and get this rapidly progressing or even slowly progressing disease where over decades they just depigment. This patient, I think, is really clinically relevant because he or she said, "I would much rather prefer repigmentation on my face as opposed to other parts of my body, just because those are the most visual areas and those are the areas that people tend to judge." And I definitely see this sentiment from my patients. They are very focused on repigmenting the face, and this is really exciting to me because it's one of the areas that I have a lot of confidence in that I can repigment with treatment. This person said, "I often feel like I'm losing the very thing that identifies me as a Black woman." And as I mentioned, there's cultural and social stigmas associated with vitiligo. And when darkly pigmented people lose their pigment, it can be very stigmatizing. And this last person said, I'm open to being treated again. I would like a medication that I could administer on my own at home. And I guarantee you, I don't know for sure, but I guarantee you that that patient probably did phototherapy, which we do know is quite effective, but phototherapy is extremely time consuming. So I practice in a university setting in the middle of the city. So someone who comes for phototherapy has to, drive into the city and parking a parking lot, go in, pay a copay, and do that twice a week. And the average working person doesn't have the time to dedicate an hour and a half twice a week to miss work to treat their vitiligo. So this can be a huge burden on patients, even though it's an extremely effective therapy. It's something that's difficult for the average busy working person who's not working virtually and has to be in an office setting. So based on all of this feedback from the patients who attended this meeting, Dr. Kendall Marcus at the FDA said there is still a significant unmet medical need in vitiligo. So let's talk about some of the current treatment options for repigmentation. We have topical corticosteroids, which are very effective, but they do have side effects because, especially for the face, we have to be careful with the side effects of thinning of the skin, telangiectasias, and so there are some limitations, especially when it comes to the face. Topical calcineurin inhibitors are one option. Oral corticosteroids can be used for people who have rapidly progressing vitiligo. Narrowband UVB is actually very effective, but as I mentioned, quite inconvenient for a lot of patients. And then there are some very novel surgical therapies that can be used where there's a donor site and melanocytes are applied to the donor melanocytes are applied to the areas of vitiligo. And the only downside to surgical therapy is that you do have a donor site, so you're going to have some sort of scar on the donor site. But previously, there's been no FDA-approved medication for vitiligo repigmentation. So what are our key takeaways? Our key takeaways are that vitiligo is an autoimmune disease that affects different populations irrespective of ethnicity, skin types, and gender. There are many factors that can influence a patient's decision to treat their vitiligo, like the course of their disease or their affected area, like the face, or the age. Younger children, parents are very motivated to treat. And we do need to understand that there's a variation in repigmentation. This is really important. I'm going to talk a lot about how to set expectations for your patients when you're treating your patients with Opzelura, because depending on the body area, it will repigment at a different rate, but we definitely know there's an unmet need for vitiligo treatments. So let's talk about Opzelura and how it works. So we're going to talk about the pathophysiology of vitiligo. And I love this beautiful graphic because it really explains it. For many of us, the concept of really the mechanism behind vitiligo and how JAK inhibitors work in vitiligo is relatively new. I went to medical school over 20 years ago, and I don't think I learned any of this. So it's very exciting for me to present this to you today because I really want you to understand how Opzelura works in managing our vitiligo patients. So let's go back to the beginning. I talked about that our patients have this genetic predisposition and then some triggering event that causes melanocyte stress. And that trigger can be chemicals, it can be some injury, unknown triggers, it can be UV radiation. I have a family member actually who grew up in Florida, and prior to the 1960s, there was no treatment for fungal infections. So many years ago, decades ago, they actually used to treat fungal infections with radiation. They would radiate the skin to get the fungus. And this family member of mine developed a stable patch of segmental vitiligo from radiation to treat a fungal infection before the development of griseofulvin, which was the first antifungal developed to treat fungal infections in the 1960s. So anything can cause it. And I mean, that's a trigger that you would never have thought of. I asked her, how did you get what happened with that patch? And she said, oh, that happened after I had radiation for a fungal infection. You could never have imagined that answer. But anyway, so we have these triggering events and you get immune cell activation. And the key player in vitiligo are these activated CD8 positive T cells. So what happens after that? I hear a little bit of feedback, but let's take a look here. So you can see here that when the CD8 positive T cell is activated, you see it releases interferon gamma. And interferon gamma acts on the keratinocytes. And when it acts on the keratinocytes start to release these inflammatory chemokines called CXCL 9 and 10. So you see this cascade because CXCL 9 and 10, what do? These inflammatory chemokines? They recruit more activated CD8 positive T cells to that area, and you get this feedback loop where you're releasing interferon, it's binding to the keratinocyte is releasing these inflammatory chemokines that are recruiting more CD8 positive T cells to come in. So what happens next is we see step 4 is melanocyte destruction and depigmentation, because there's just so much inflammation targeted to those melanocytes, and they basically can't survive and they stop making pigment. So we're going to go to the next slide, and we're going to look at what goes on inside of the cell. Now, this is where I think this is so interesting, because the JAK-STAT pathway is this as a key driver for depigmentation of vitiligo. So JAKs are enzymes that belong to a family of intracellular non-receptor tyrosine kinases. So we have JAK1, 2, 3, and TYK2. But we're going to focus on JAK1 and 2 for this talk. So the JAK-STAT pathway is pivotal to the downstream signaling of these inflammatory cytokines. So what happens? So you can see this little box here, which is on around the keratinocyte and around the CD8 positive T cell. If we blow this up, we can see that interferon gamma receptor on the surface of both the keratinocyte and the CD8 positive T cell. So when interferon binds to its receptor, in either of these two cells, you get activation of the JAK. In this case, we're talking about JAK1 and 2. And when the JAK is activated, the JAKs are activated, they activate STATs, which are signal transducers. So the STATs come in, they get activated, and then they pair up and go to the nucleus, and they basically tell the nucleus to make more inflammatory chemokines. So this is what happens. It tells the nucleus it activates gene transcription, and we see more inflammation. So this is that vicious pathway, but we're looking at a very high level, right inside the cell. So now we're going to talk about what happens in the presence of Opzelura. So Opzelura is thought to inhibit this interferon gamma mediated JAK-STAT signaling. So you can see here that these kind of pretty rainbow colored droplets are applied to the skin. So we're applying it right onto the skin, but they actually go inside of the cell. The active ingredient goes inside of the cell and acts as a JAK inhibitor. So they bind the JAK there. So even though the interferon has bound to its receptor, those JAKs cannot be activated because they're being inhibited by the JAK inhibitor. So then the STATs come along, but the STATs don't get activated. You can see here the STAT has nowhere to bind. They can't get activated, and they can't go to the nucleus and tell the nucleus to produce more inflammatory cytokines. So this JAK inhibitor reduces inflammation in the skin via this mechanism. So let's see, you can see here that once you have the JAK inhibitor binding to the JAK, the STAT doesn't get activated, you see a reduction in the CD8 positive T cells, and you see a more stable environment for melanocytes. So the melanocytes are now kind of not under attack, essentially, because basically the melanocytes have been under attack, and patients with vitiligo, the melanocytes are under attack and they really can't produce melanin. Now it's a more stable environment, and the melanocytes can start to produce pigment again. So how does that happen? How that happens is that for the vast majority of repigmentation is actually perifollicular repigmentation. So stem cells migrate into the skin from the hair follicles. That's why it's so important to have pigmented hairs. If you have leukotrichia and you have white hairs, it's much harder to repigment. But if there are pigmented hairs, we have these stem cells, these melanocyte stem cells that migrate up the hair follicle and establish themselves again in the skin, and then you get repigmentation. And that perifollicular repigmentation is the quickest way to repigment. But there are actually two different ways to repigment. The second way to repigment is marginal repigmentation. That's pigmentation from the outside in, and that's what we see right here. So you can also see pigmentation from the outside of the vitiligo lesion, making it a little bit smaller, but that takes much, much longer. The quickest way to repigment is from the hair follicles. So now I'm really excited to talk about the FDA trials that led to the approval of Opzelura. And these are the results from 2 phase 3 randomized double-blind studies in adult and pediatric patients 12 years of age and older. And I do a lot of clinical research, so these slides are always fun for me, and I'll make sure that they're fun for you because I love really well-designed trials, and this was a really well-designed trial. So the trial was called TruV1 and TruV2. They were identical phase 3 trials. And the patients who were eligible to enroll were adults and adolescents, 12 years of age and older, with non-segmental vitiligo. They needed to have around a greater than 0.5% facial body surface area and greater than or equal to 3% non-facial body surface area. So, and then for their total body vitiligo, it couldn't exceed 10% body surface area. So let's talk about that. Many of us in dermatology know the concept of that the palm is equivalent to 1% body surface area. Every study is different, and I do a lot of clinical trials. In this particular clinical trial, 1% body surface area was the palm, including the fingers, so the hand. So you can have 10 hands, up to 10 hands of vitiligo on the body, or no more than 10 hands of vitiligo on the body to qualify for this, and you had to have facial vitiligo, and that was actually a primary endpoint. We're going to talk about that in a minute. Phototherapy obviously was not permitted, and patients who had complete leukotrichia or white hairs in any facial lesions were excluded for obvious reasons, because you know that it's much, much harder to repigment if there are no pigmented hairs. So then the patients were randomized 2 to 1. So 2/3 of the patients got Opzelura twice a day. There were 450 people in that group. And 1/3 of the patients got the vehicle. There were 224 subjects in that group. And they were treated for 24 weeks. Now, 24 weeks is a 6-month endpoint. And those of you who know about clinical trials, like for other skin diseases, for example, acne, usually we have a 12-week endpoint, because it's relatively easy to, I wouldn't say easy, but easier to clear up acne in 3 months. But now that you understand this whole mechanism behind vitiligo, that not only do you have to stop the inflammation, but you also have to allow time for those melanoblasts to travel up the hair follicles and to reestablish themselves in the skin. And that takes time. And so that's why the endpoint is 6 months. So that's an important take home. If you're treating your patients with Opzelura, definitely give them time to get better, because this process does take some time. At 24 weeks, that was the endpoint for the FDA, and we're going to look at the data at that point. But then after 24 weeks, the people in the vehicle group were allowed to get the Opzelura, so they transferred over into the active group, and that there was an open label treatment extension that was 28 weeks long, and that ended up being a 52-week study, and then there was a follow-up 30 days later. So usually at the end of studies, we call patients around a month after the study ends to see how they're doing. So what were the endpoints for this study? The primary endpoint for this study was the proportion of participants achieving a 75% improvement in their facial vitiligo area scoring index, or the FAAD. The FAAD is a score that we use to score vitiligo, and it's similar. It's not identical, but it's similar to other scores that we use in dermatology, like the PASI and the EASI. So it's an easy way for us to show improvement. So if they got an FAAD of 75 on the face at week 24 at 6 months, that was considered a clinical success by the FDA. Now, there were many secondary endpoints in this study, and the first selected secondary endpoints were the people who achieved 75% improvement in their FAAD at 52 weeks. So the primary endpoint was 24 weeks or 6 months, but there's a secondary endpoint of an FAAD of 75 at the end of the study, so 1 year. And then also the proportion of patients who had a 75% improvement in their T-VASI at 52 weeks. So FAAD refers to facial vitiligo, T-VASI refers to total body vitiligo. The other key secondary endpoints were an FAAD of 90, that's the proportion of participants achieving a 90% improvement in their facial vitiligo scores at 6 months, an FAAD of 50, so that's a proportion of patients achieving a 50% improvement in their facial vitiligo at 6 months, and a T-VASI 50, which is the proportion of patients achieving a 50% improvement in their total body vitiligo at 6 months. So let's look at the data. The patient demographics, I think, are interesting. The patients were middle-aged, I guess 40. I don't know if that's middle-aged. I think that's young, but that's because I'm 50. But the patients were around 40, all different skin types. So skin of color was very well represented in this trial, which is very exciting for me because I do specialize in skin of color. But what I do want to point out to you is that the duration of disease, these patients on average had their vitiligo for over a decade. So they really were people who had been walking around with facial vitiligo for many, many, many years. And I think that that's very clinically relevant because you're going to see some beautiful before and after pictures that we saw in the study. And I think that's a long time, you know, to have facial vitiligo for 10 years, to have something that can treat that is exciting. So now we're going to look at this primary endpoint that was set forth by the FDA. So that's the FAAD at 24 weeks. So you can see here in this green column here, this is the primary endpoint. And I mentioned at the beginning, this is a very well-designed trial. You know it's a very well-designed trial because in both groups, the TRuE-V1 and the TRuE-V2, the results are identical. 29.9% of subjects achieved a FAAD 75 at 24 weeks. That means almost 30% of patients had a 75% improvement in their facial vitiligo at the end of the 6-month endpoint for that study. I also want you to look at the column on the left of that. So that's an FAAD 50, so a 50% improvement. And you can see that very similar numbers, 51% of subjects in both studies achieved an FAAD 50 at the 24-week endpoint. So let's take a look at what that looks like clinically. Let's see here. So this is a patient who was a treatment success. So you can see at baseline, she has vitiligo on her cheeks, her eyelids, the root of her nose, and her forehead. At week 12, she's looking good. Her cheeks filled in. This is typical of what I see in my clinical practice. Her eyelids starting to fill in, and her forehead is starting to fill in. And then at week 24, you can see that she only has a little bit on the medial eyelids and on her forehead. She has an 80% change, and therefore she's considered a clinical success. Now, this is another patient we're going to see in a minute, and this patient has a very dramatic improvement at 24 weeks. So you can see that he achieved an FAAD 90, which is one of the secondary endpoints that I mentioned. So at baseline, this patient really has vitiligo affecting his entire face. And keep in mind, as I said, most of these patients had vitiligo for over a decade. So I wouldn't be surprised if he was one of those patients who fell into that group. You can see at week 12, those islands of repigmentation, he's looking really great. And then at week 24, he's almost completely filled in with the exception of his lower chin here and around his lips. So he has a 91% improvement. So he has an FAAD of 90 at week 24. Now, the next picture that I'm going to show is quite interesting because remember I talked about the primary endpoint for this trial was an FAAD 75, and this patient has an FAAD of 50, right? She met a secondary endpoint, but not the primary endpoint. And you can see that she has vitiligo on her cheeks, her eyelids, a little bit in her eyebrows, and you can see at the end of the study at week 24, there's a 68% improvement. Now, this patient, if she was in our clinical practice, would be ecstatic, but she actually didn't meet that primary endpoint by the FDA because remember, the FDA required a 75% change at the end of 24 weeks. So this gives you an idea of she would not be included in that 29.9% that I said met that primary endpoint, although she is an excellent, has excellent results. This patient is ecstatic. I know if she was in my practice, she'd be very, very happy with these results. So this is very exciting for me as someone who treats a lot of pigmentary disorders, because it's very predictable, the findings that we see here. So now we're going to talk about the FAAD 75. That's a 75% improvement in facial vitiligo at 52 weeks. So 50% of subjects in the active group met that endpoint. But what's really interesting about this slide is this week 8 time point right here. If you notice right here with week 8, there's no difference between the active and the vehicle group. And why is that important for us as clinicians? It's important because you don't want to bring your patients back too early. Don't bring them back in 2 months, because you're not likely to see improvement. As you know, this is a long process to stop the inflammation and then to get those melanoblasts to come back up and kind of repopulate the epidermis. So it takes some time. So I bring my patients back at around 4 months, because that's when you really start to see that improvement and see how they're doing. So I love this slide because it really teaches us that you don't want to bring the patient back in 2 months. Set realistic expectations so that they don't expect to see difference in a week or 2 weeks. It really takes some time, but once it starts working, it really does work well. So as I mentioned, this is the FAAD 75 at 52 weeks at the end of the long-term study. 51% of subjects met that criteria. So let's take a look at one of those subjects who met that criteria. This is a patient who achieved an FAAD 75 at 52 weeks with Opzelura. So this is his baseline. You see the vitiligo primarily around his mouth and a patch in his eyelids and on his forehead. And you can see here at week 24, he's filling in, but at week 52, what a dramatic improvement. You see that 78% improvement, or 78% change in his FAAD. And again, this patient would be ecstatic, because 1 year later, the vitiligo is essentially gone clinically, but what we would consider gone. It's a 78% improvement, but clinically, he looks great. Now let's look at the FAAD 90 at 52 weeks. So these are patients who had a 90% improvement in their facial vitiligo at 52 weeks. 31% of subjects met that secondary endpoint. So let's take a look at that. So this is an adolescent patient. And the reason why I think this subject is really interesting is because in my practice, vitiligo in adolescents and teenagers, it can be devastating. That's probably the worst time you could possibly have vitiligo. So for her to have an improvement really would have a tremendous impact on her quality of life. You can see at baseline, she has this involvement around her eyes, her nose, and her around her mouth. At week 24, she's looking really good. And at week 52, you see a 99% improvement in her facial vitiligo. So she must have a little patch somewhere hidden by one of these black squares, but she really had complete clearance, almost complete clearance of her vitiligo at the 1 year time point. So that's very exciting, especially for someone who does treat adolescents with vitiligo. To see this type of result would be life-changing for these patients. Now let's look at the FAAD 50. So that's a 50% improvement at 52 weeks, so at the end of the year. 75% of subjects met that endpoint. So let's take a look at what that would look like. So we're going to see a patient. She has mainly on one side of her face, almost a segmental look, but it does cross the midline here on her upper lip. And you can see at baseline, the areas that are affected. At week 24, it starts to fill in a little bit, especially on her upper lip. And then at week 52, there's a 62% change, and she falls into that endpoint of an FAAD 50 at 52 weeks. So we're going to move from facial vitiligo. So you've seen really predictable good results on the face. I want to talk about total body vitiligo. So the endpoint we're going to look at next is the FAAD 75. That's a 75% improvement in total body vitiligo at 52 weeks. 21% of subjects met that endpoint. So let's look at what some of those subjects look like. And this is the in TruView 1 and TruView 2, you can see that 20% here and 26% of here. met that endpoint of a T-VASI 50 at week 24. So this is one of the subjects who had met that endpoint, the T-VASI 50 at week 24. And you can see at baseline, we see pictures of the arm and chest, but this person had vitiligo on other parts of the body. But at baseline, you can see here the big, large patch on the arm and the chest. And at week 24, we see these beautiful islands of repigmentation on her arm and her chest. This is a 51% improvement, so she met that criteria of a T-VASI 50 at week 24. Now, this slide just basically shows you where else she had this on her body. So she had, of course, facial involvement, because to get into the trial, you had to have facial vitiligo, but she also had vitiligo on her trunk and other parts of the body. Now we're going to look at a T-VASI, another patient with a T-VASI 50 at week 24. So this patient at baseline, we're going to look at her elbows and her feet. And you can see at week 24, her elbow fills in completely. Well, they say it's 61% change, but it looks 61% overall for her T-VASI, but the elbow looks like it's completely filled in. The feet are a little bit harder, and that's exactly what I talked about at the beginning of this talk, where I mentioned that feet take a little bit longer to repigment. But you can see at week 24, she is starting to repigment here. And then this next slide will just show you the other parts of her body where she had it. She also had involvement of her trunk and her face and other parts of the body. Now we're going to look at the T-VASI 50 at 52 weeks. So that's 50% improvement in the total body vitiligo at 52 weeks. So we can see that 51% of subjects met that endpoint of the T-VASI 50 at week 52. So let's take a look at what those patients look like. So this is a younger patient, an adolescent, who had vitiligo on the knees. And you can see at baseline and at week 52, the right knee is filling in. He primarily has, I think this is quite interesting, marginal repigmentation from the outside in. He doesn't show that classic islands of repigmentation that we expect in areas with body hair. But his left knee fills in completely at the end of the 52 weeks. And so he's considered a 52% improvement, or a T-VASI 50 at week 52. And of course, as I mentioned, he had it on other parts of his body, including the face, but we're looking at the T-VASI, we're looking at the total body scores. So just as important as efficacy is treatment emergent AEs. I do a lot of clinical trials, as I mentioned, and it's really important to me to look at the safety. So let's look at some of the safety data at 24 weeks. So it's important to note that this study did start during the pandemic. So we're going to see some side effects associated with the pandemic, which I think is quite interesting. So at week 24, we can see that the most common side effects were application site acne, application site pruritus. There was also nasopharyngitis, headache, UTI, application site erythema, and pyrexia. These were the most common treatment emergent AEs at 24 weeks. Now, as we got a little further into the pandemic, these are the treatment emergent AEs at 52 weeks. You can see here that a lot of patients got COVID-19. Now, that's very common in clinical trials. For those of you who don't do clinical trials, we report everything that happens. So if the person stubs their toe, we write down the patient stubbed their toe. We write whether it was mild, moderate, or severe, and the investigator assesses whether it was related or not related. So obviously this occurred during a pandemic, so this was not unexpected, I would say. So at the end of 52 weeks, the most common treatment emergent AEs were COVID-19, application site acne and itching, nasopharyngitis, and headache. But what we are most concerned about is what the investigator felt was treatment related. Because remember, ISS, when we're doing these types of clinical trials, we report everything. We report whether it's mild, moderate, or severe, and then the investigator assesses whether it's treatment related or not. So this is the area that I like to focus on when I'm looking at clinical trial data. And we see here that application site acne and application site pruritus were the most common treatment related AEs, and they were at a low rate of around 5%. And there was only one AE that led to the discontinuation from the study, which was 0.5%. So what did we learn today? We know that Opzelura, which is ruxolitinib, 1.5% cream, is a non-steroidal topical cream. It can be used on sensitive skin areas, so we can use it on the eyelids, around the mouth. We saw lots of patients with eyelid and mouth involvement with really great results, and on the external genitals. It is for topical use only and not for intraocular, oral, or intravaginal use. We use it 2 times a day, so a thin layer is applied twice daily to affected areas up to 10% total body surface area. Remember, for this trial, it was the palms and the fingers, so 10 hands. It's an area that we treat, and we want our patients not to use more than 60 grams, a 60-gram tube per week. I've never run into that, but we always have patients who, eventually I'm sure I will. So we advise our patients, we wouldn't want them to use more than 60 grams in a week. So it's just as important. I always say, you know, we want to know about efficacy, and we went over efficacy with really nice results. We went over safety, but what's also equally important, how can our patients get this medication? So the great news is that there is a copay savings program. We tend to use specialty pharmacies in my practice, and we kind of send this in through the specialty pharmacy, and they do tend to process these copays. So it can be as little as $10 up to $50 through the specialty pharmacies. And then there is also a patient assistance program. So there are ways for us to get our patients this drug. And I find in my practice, my vitiligo patients are highly motivated to get this new treatment because it's the first treatment that has been FDA approved for vitiligo. So let's see, here we go. So I told you we were going to start and we're going to end with the important safety information. So as I mentioned, JAK inhibitors are a class of drugs, relatively new, and they were first introduced in the rheumatology world. So they have been used to treat rheumatoid arthritis and other diseases by rheumatologists. This class of drugs has some important safety information that I want to talk to you about. So patients treated with oral JAK kinase inhibitors for inflammatory conditions are at risk for developing serious infections like TB, fungal, bacterial, viral, and herpes zoster. So we would avoid using Opzelura in patients with active serious infection, including localized infection. And if our patients developed a serious infection, we would stop using Opzelura. Serious lower respiratory tract infections were reported in the clinical development program for topical ruxolitinib. There were no cases of active TB in the clinical trials with Opzelura, but obviously if our patients had signs of TB, we would monitor for that and discontinue. Viral reactivation, including cases of herpes virus reactivation, were reported in clinical trials with JAK kinase inhibitors to treat inflammatory conditions, including Opzelura. So if the patient develops herpes zoster, we would just interrupt the treatment until the episode resolves. And then hepatitis B viral load increases with or without elevations in LFTs have been reported in chronic Hep B infection patients taking oral ruxolitinib. So Opzelura initiation is not recommended in patients with active hepatitis B infection or hepatitis C also. Now, as I mentioned, JAK inhibitors have been used a lot for rheumatoid arthritis. So in large randomized post-marketing safety studies in rheumatoid arthritis patients 50 years of age and older with at least one cardiovascular risk they compared an oral JAK inhibitor to a TNF-alpha blocker. And what they found was a higher rate of all-cause mortality, including sudden cardiovascular death, with the JAK inhibitor. So we would consider the risks and benefits for patients who are at high risk or have lots of cardiac disease. Malignancies were also reported in that study. So lymphomas and other malignancies were observed in patients receiving JAK inhibitors to treat inflammatory conditions. In rheumatoid arthritis patients treated with JAK inhibitors, there was a higher rate of malignancies compared to TNF blockers. So again, we would consider the risks and benefits in starting or continuing Opzelura in patients with known malignancy. Now, non-melanoma skin cancers like basal and squamous cell carcinoma have been reported in patients treated with Opzelura, so we would do our routine skin checks like we always do in our dermatology patients. There's another important safety information that some more important safety information I want to discuss, and that's the major adverse cardiac events or MACE events. So again, in this rheumatoid arthritis patient population, 50 years of age and older with at least one cardiovascular risk factor treated with an oral JAK, there was a higher rate of MACE compared to TNF blockers. And so we would again consider the benefits and risks in our patients who have lots of cardiac issues. Thrombosis, similarly, such as PEs, DVTs, and arterial thrombosis have been reported in patients using JAK inhibitors to treat inflammatory conditions. And many of these were serious and did result in death. So, and particularly in that rheumatoid arthritis population. So we would avoid Opzelura in patients who are at risk for those conditions. We're almost done with the important safety information. I just want to go over some lab findings. So thrombocytopenia, anemia, and neutropenia were reported in the clinical trials with Opzelura. So we would consider the risk for patients with known history of these events. Lipid elevations were also reported. So again, we would consider it if our patients have uncontrolled cholesterol issues. But what I think is most significant for the vitiligo trials, and this is really important because specifically for the vitiligo, for non-segmental vitiligo, the most common adverse reactions were application site acne at 6%, application site pruritus at 5%, nasopharyngitis at 4%, headaches at 4%, UTIs at 2%, application site erythema at 2%, and pyrexia at 1%. So the most common things were these kind of localized reactions, specifically the acne and the pruritus, at low rates of around 5 to 6%. We wouldn't use Opzelura in patients who are pregnant or lactating, and there is a pregnancy registry if we have a patient who's exposed to Opzelura during pregnancy. So now we are going to end with this slide, and I want to talk about how, just a quick summary of all of the things that I've discussed. Let me go back a little bit. Let's see. And one more. I think it might, let's see if it stays there. Perfect. So, so we do know that Opzelura is the first and only FDA-approved topical JAK inhibitor for patients with non-segmental vitiligo in adult and and it's approved for adult and pediatric patients 12 years of age and older. We went over the mechanism here by inhibiting that interferon gamma mediated JAK-STAT signaling, which is the driver of depigmentation in vitiligo. We saw that the primary endpoint, 1 in 3 participants achieved an FAAD of 75 at 24 weeks. 50% of patients achieved an FAAD of 50 at 24 weeks. And in the open label extension at week 52, 51% of patients achieved that FAAD of 75. It's really important to set realistic expectations with our patients because the repigmentation process is slow. So you don't want to bring them back in a month or 2 months. Give them a good 4 to 6 months so they really can see those results. But the great news is this is a non-steroidal cream, so it can be used on sensitive areas, which is particularly important for vitiligo because it tends to affect around the eyes and around the mouth. And we just went over these most common adverse reactions, which the most common ones were application site acne and pruritus. So thank you so much. I hope you learned something new in this talk, and we welcome your questions.
So please submit your questions using the question chat pane on the right-hand side of your screen. If you have any additional questions after the webinar, you can always send them to info@idefeducationalseries.com. Again, we'd like to thank our supporter, Incyte Dermatology, for making this educational event. So we have a couple of minutes to take questions from our audience.
Well, first of all, Heather, that was incredible. I mean, I learned so much. My head is kind of spinning. I think we're really fortunate right now that we actually finally have something for vitiligo because we've had nothing. We've had little bits and pieces of different therapies, but now we actually have something that we can write a prescription for, and it works, and it looks like we can get it. There are a couple of questions that I see on the question pane here. So question 1, how long should a patient stay on Opzelura to get that maximum repigmentation effect?
Well, we do see from this clinical trial, we have 52-week data, which is very exciting. And I do know that there are studies ongoing looking at even beyond that time point. But the great news is that we do have 1-year results, and those results were quite impressive, as you could see.
Yeah, fantastic. That was going to be my follow-up question. Are there continuing studies so we can get a little bit more information, particularly since I have to say it kind of reminds me of alopecia areata, that you gotta set the bar properly with the patients in terms of the time frame. And then this question is very interesting here. Can Opzelura be used with makeup and sunscreen?
It can be. So it's a cream, which is, I have a lot of female patients, and it's a cream, so it's not an ointment, and that makes it very helpful because it's easy to apply, absorbs well, and then you can. So I always tell my patients medicine first, and then everything else on top. Sunscreen last.
How long do they have to wait? We get asked that all the time. I'm putting my medicine on.
Right.
How long would you have them wait?
Just a few minutes. I don't think there's like this specific a special time point. It does absorb very well. So, a minute or two, brush your teeth or do, whatever you do in the morning, just one other thing, and then you can, put on your makeup and your sunscreen.
Well, we'd like to thank Dr. Heather Woolery-Lloyd for really groundbreaking presentation, and also this exciting new therapeutic option for vitiligo patients. And also thank you so much, Dr. Glick, for helping us moderate this evening. Please stay tuned for our next webinar, where we are also going to be talking about targeted approach to non-segmental vitiligo on November 22nd at 7 p.m. Eastern Standard Time. You can also visit idefeducationalseries.com for more information. And thank you all for joining us this evening. Good night.